Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we have the pleasure of having His Excellency Dr. Jean Kaseya, the Director General of Africa CDC, joining us for this briefing. I will now hand over the floor to Dr. Kaseya to start the session. Over to you, DG.
Thank you so much, Margaret. Good morning, good afternoon, even good evening to some of our colleagues who are joining us online. It's a great pleasure for me to be with you, especially because we are almost 12 months after the declaration of Mpox as the public health emergency of continental security, and also public health emergency of international concern by WHO. I think today we'll mostly focus on what did we do, the 12 months of response, and what is remaining to make sure that this Mpox linked to other outbreaks, we will win and we can stop that. Let us move to the first slide, please. This is just an overview. Yes, this is an overview to show if we compare 2024 to 2025 so far, we can see on your right side, you have the map for 2024, all public health event that we had. That was 219 public health event. But if you compare to 2025 in August, we already have 143. We don't know what will be other public health event we can have in the coming weeks and months. But this is just to give you an idea that we still have a major concern in terms of outbreaks in Africa. And you'll see there are 4 major outbreaks that we are managing. Cholera, we'll talk about it, affecting 23 countries. Mpox, 24 countries. Measles and dengue. We'll mostly focus on cholera and Mpox today. Next slide. This is the first press briefing we had when we declared Mpox as the public health emergency of continental security. I thank my colleagues who managed to find the photo when I was making this declaration. But why did we do that? Why did we make this declaration? Mostly for the 5 leading reasons that we are providing to you. First, we saw the unprecedented, sustained human-to-human transmission. It was not the case in 2023, 2022, and other years. The second one, we saw a major and rapid increase in terms of countries affected. And we saw also in terms of case and even people who were dying due to Mpox, that was a major increase. We also had this inadequate continental preparedness and response capacity that wanted to address by putting in place a mechanism that we call IMST. You are now familiar with that. This is the Incident Management Support Team to respond to this outbreak. And one of the reasons that WHO declared also Mpox as public health emergency of international concern, because there was a major risk to affect other continents. Next slide. I will just remind you this slide. It was the slide that I presented to you when I made a declaration in 2024. We had 13 countries affected. We had at that moment 17,541 cases. That was an increase of 160% comparing to 2023. And we provided even per country the clades that were predominant at that moment. Next slide, where are we now in 2025? If we compare the same period in 2025, January to August, you will see that we moved to more cases, suspected cases, even confirmed cases. We'll see the reason for that. And we have more deaths linked to suspected cases, but not to confirmed cases, because we want to maintain deaths related to suspected cases. In 2024, we didn't have confirmed cases. We are referring to suspected cases. But you'll see how these Mpox moved from 13 countries to 24 countries, almost 10 more countries after the declaration. And this is something we need to keep in mind, because we'll see, despite all effort that we, the team and the member state, they managed to come together and to respond to this outbreak. Despite all of that, we still have an increased number of suspected cases, even confirmed cases. Next slide. Before moving to quick analysis of what we did, we wanted to compare the trend. We have the 4 high burden countries, DRC, Burundi, Uganda, and Sierra Leone that came later. And you see, from January to August, we can see a decrease in terms of confirmed cases. A number of countries, Sierra Leone, Burundi, Uganda, they are testing almost 100% of their cases. It means we are mostly talking about suspected cases that became confirmed cases. And you can see the decrease in terms of these confirmed cases. Even in DRC, we can see the decrease. This is why we are saying, despite the fact that there are new countries, the 9 new countries that we are sharing with you in the screen, but the major trend is mostly to see that decrease in terms of cases. Next slide. Even if I compare the previous week to the current epidemiological week, that is the week 31st, you'll see a decrease in terms of cases. That can be suspected cases or confirmed cases. You will also see a decrease in terms of deaths. Now, mostly deaths related to confirmed cases are 2 this week compared to 6 last week. We want to see this trend being sustained for the next week or coming weeks. That can open the door for the ECG when they will meet our experts to maybe to advise the DG to lift the status of public health emergency of continental security. Next slide. Now let us start analyzing what we did, because it's important for you as journalists to know that we started from almost nothing, but we made huge progress. When we declared public health emergency, Mpox public health emergency of continental security, we had only 20,000 doses pledged at that moment. 0 landed in Africa. Today, we have more than 6 million doses, and we already use around more than 3 million doses. You will see that even number of countries that received vaccines moved from 0 to 12. Number of countries rolling out vaccination activities from 0 to 12, and number of people that got at least 1 dose of vaccine, it's around 886,000. Yes, we made progress in terms of vaccination. Yes, we need more doses because, as we see, Mpox is still a major public health emergency, a major public health issue in Africa. But let us also start to celebrate some success, because vaccine was not what we are thinking to make huge progress like that. Next slide, please. I wanted to show you in terms of diagnostics how we moved. In January 2024, if we take just DRC, that is the most affected country, we had only 2 labs, Kinshasa and Goma. We started to support the country. And we moved from 2 to 12 in December 2024. I can remember I was in DRC in January 2025, meeting the president and colleagues from INRB, the national lab, and we're discussing the progress that we made, moving from 2 to 12 labs. And now that I'm talking to you, we moved from 2 in January 2024 to 69 labs with a number of capacities like Radio 1, Gen Expert, qPCR, and our objective is to cover all regions, all district, sub-regions and districts in DRC by December 2025. We made huge progress. You will see that it's just not DRC, but also other countries. Next slide. You will see, like for Burundi, we moved from 2 to 56 labs. And these are just the 2 high-burden countries, but this trend is almost in all affected countries, where we managed to provide technical support, building capacities of colleagues. We trained around 850 staff in this area, the lab area. We managed to develop and to deploy what we call the technical guidelines. And as you know now, it's the decentralization strategy that is supporting what we did in DRC, in Burundi, in other countries. We managed also to provide to countries, equipment and also to build infrastructures like what we are doing together with World Bank in DRC and other countries. The genomic surveillance also, we moved, you can see how we are sustaining our approach. Except maybe DRC, most of our countries affected are maintaining 100% Mpox testing rate. And we know why the case is in DRC for security issue, but also because of funding a gap from partners for transportation of samples. We made a lot of progress in the lab area. Next slide. As we made also in other areas like surveillance system. You'll see how we moved. We have the number there. Suspected cases, samples that we collected and analyzed. And you see for all indicators that we are showing, we made huge progress. That is helping us now even to report more cases than it was before. I have to say that when we declared Mpox public health emergency of continental security, that the data that we provided, we could not say it was accurate because we didn't have the surveillance system in place, the lab capacity in place, people trained, but we started now to build this capacity. This is why you can have the impression that we have more cases than what we had in 2024. It's just because we managed to support strong surveillance and lab system. Next slide, please. When we detect cases, we need to manage these cases. We made also in major progress in terms of case management by providing capacity to almost all countries. We supported 12 member states to build their capacity on case management. We organized webinars. We trained more than 3,000 health workers, and we managed also to provide some support in terms of food assistance and others. I think if you see a country like Burundi, as you will, I will show you when I will talk about Burundi, we only had one death because the case management was solid and they were following the guidance that we provided. Next slide. Wanted to talk also about funding. When we launched the IMST and the response plan, we're targeting more than $500 million. But we got, thanks to the integrated approach that we had, thanks to all partners coming together, all member states coming together, we managed to get a pledge of $1.1 billion. Out of the $1.1 billion, we are tracking $979 million because we know who provided what, going where, and the impact of this money. This is the first time I have to say that Africa can provide appropriate and reliable data in terms of finance, because it's the first time that Africa is managing a major outbreak. In the past, it was not an African body doing that. Out of what we received, we had a remaining fund of 196 million, and you will see, next slide, we need 429 million, or almost $430 million to respond based on the second phase of the response plan to fulfill our mandate. But out of this 430 million, as I said, we have almost 190 million remaining. We have a major gap of more than $224 million. This is the gap that we need to see how to fill. You have in your screen the breakdown of this budget and where money will go. You will see that vaccination and logistics, in addition to surveillance, are the major budget lines taking more than 50% of the budget we are looking for. Now, what we are doing is really to sensitize our member state and our partners to provide more funding to fill the gap. We start to see a trend based on the Rethinking Africa Health Financing in a New Era that we released this vision that had to bring together head of state and ministers and communities. We start to see a major change in terms of domestic resources. I will have opportunity to talk about what I saw in DRC last week by increasing the domestic resources with some taxes. And this is what we want to see in most of our countries in Africa. Next slide. Then quickly, I will not comment, but you'll see just in the 4 high burden countries, the decrease, like in Sierra Leone. Next slide. You have it in Uganda. You can see the trend. Next slide. In Burundi also, except for the past 2 weeks, we saw a slight increase in terms of suspected cases, but the trend, especially in terms of confirmed cases, we can see the decrease. Next slide. This is also the case in DRC. We can see also that decrease we are talking about, even if, as we said, due to some reasons linked to insecurity, linked to issues in terms of sample transportation, but we can see the decrease we are talking about. Next slide. Now, after talking about Mpox, let us quickly, in the next 5-6 minutes, talk about the cholera. As you know, 2 months ago, I organized a meeting of head of state, African head of state, coming from countries affected by cholera. I wanted to show you the trend from 2022 to 2025. You'll see number of countries affected. We moved from 15, and it's like every single year there is an increase in terms of affected countries. So far, we have 23 countries. We don't know if that will be the number in December or we'll have other countries coming in addition. But you also see the same trend in terms of cases. In 2025, from January to August, we have almost what we had from January to December in 2023. We have more than what we had in 2022. And if we continue with this trend, what I can see, 2025 will have more cases than 2024. In terms of case fatality, yes, even the average of case fatality is increasing, but we'll see. It's mostly driven by a few countries where even the case fatality rate was 10%. This is the case of Congo-Brazza. When I visited Congo-Brazza a week ago, the case fatality rate was more than 10%. Now you'll see it's 8%, but it's still high. And we are supporting countries in all of this multi-sectoral approach to end cholera. Next slide. We are talking about Congo. You'll see 8.2% of the case fatality rate out of 425 cases that they got. And I was in Congo-Brazza a week ago to meet Congolese authorities and discuss about the response, because when I saw the data, I saw 10%, I say I will give my priority to Congo-Brazza. We managed to bring support for them to finalize the response plan, and we even saw how we can fill the gap. At that moment, we were talking about $1.7 million. And I think all partners are coming together, including Africa CDC. We are providing around 500,000 to Congo-Brazza, including donation of some supplies and colleagues in the field. This is what we are doing to support the response, but to build also the system, because we want this country for next time to be able to prevent this kind of outbreak. Next slide, if we move to DRC, I was in DRC from Friday to Sunday, meeting the president, the prime minister, the minister of finance, the minister of health, and all other partners. I'm glad to share that DRC disbursed $5 million to respond to this outbreak out of the 17 million they are looking for. This is why we see that this is the trend, the positive trend we need from our countries. And we are working with other partners to see how to fill the gap. I wanted to share that DRC is seriously affected by this cholera. We are talking about 44,000 cases and more than 1,300 deaths. I think now our approach in DRC and other countries is to have what we call a combined response, an integrated approach to respond to Mpox, cholera, and other outbreaks. And currently, cholera is benefiting from the lab network that we created that is helping to report more cases. It's also benefiting from the community approach that we managed to put in place for Mpox, and also other support that we provide to build capacity of health workers, and also funding from partners and the government. Next slide. We'll see in Angola, I visited Angola 3 times, and with a strong political will, with a strong a multi-sectoral approach, we see the decrease of cases in Angola. And now they are building on that to make sure that the country is well prepared. We provided youth support in terms of capacity building, in terms of wash supplies, in terms of laboratories. I think the country is building on that to see how to build a resilient health system while they are making a strong move in terms of water sanitation for all areas. Next slide. I wanted to show also Chad, because the case fatality rate is 5%. This is more than the average that we have. But this is also an example to show that when we have insecurity, this is a major driver of cholera. You will see in Chad, more than 93,000 people came back in some regions, and that without being prepared for the wash system, and it created this cholera, major cholera outbreak. We are expecting, if nothing is done, to see the same trend in the eastern part of DRC. This is why I think you saw our tweet. We managed to convince DRC, Rwanda, and the US to put in the regional economic framework that they developed after the peace agreement, to put there a strong public health approach that will be led by Africa CDC, not only for the 2 countries, but for almost 7 countries, because that is a regional approach for the economic side of the peace deal. My last slide to you today, colleagues, is almost to share with you that, yes, after 12 months, the team and member states are working tirelessly to stop the Mpox. But we need to recognize this is the first time Africa is investing on Mpox. When the world declared the public health emergency of international concern from 2020 to 2022, Africa didn't have this capacity. It's now that we are building capacity. We believe the positive trend we see in the 4 most affected countries, but also in other countries, will continue. This decline will continue, and we can open the door for our experts to come in a few weeks to tell us if we need to lift or not the public health emergency of continental security. We are celebrating the success in terms of vaccination. I can remember when we started, some partners were telling me Africa doesn't want vaccine. But we see with the Mpox vaccine, almost zero resistance. The vaccine is well accepted. The only issue we have is lack of vaccines. And we are thanking Gavi. We saw the outcome of the Gavi board that is dedicating some funding for Mpox stockpile. I think that one will help us with some innovations that we are bringing to respond to the challenge that we are facing. I will stop there, welcoming your questions, not only I think on that, but I know you have a number of questions even on other initiatives we are taking, local manufacturing, health financing, and others. We are glad to share some update with you. Over to you, Margaret, for our colleagues journalists.
Thank you, DG. Just to let the audience know, we have been joined by Dr. Mori Keita, the WHO Incident Manager for the IMST. Welcome, Dr. Mori. I will now take the first 2 questions. We have Dorcas Wangira of the BBC. The question is, it's 1 year since Mpox was declared a public health emergency of continental security in Africa. Where does the continent stand in this outbreak? That's the first question. And then the second question is from Richie Gemma from The Outlier. The question is, how are changing weather patterns linked to the new outbreaks of cholera? Those are the first two questions. I'll hand over back to you, DG.
Thank you so much. I think our colleague Dorcas could find some of the response in the presentation just I made. You know, I wanted mostly to show you where the continent is standing now in terms of effort. You see, if we break down financing, we made a lot of progress, but we still have gap. Some Western countries, they committed. We are still waiting to see pledge becoming real money. We made progress in terms of vaccines, 6 million doses of pledge, and we already used around 2.5 million in 12 countries. We made progress in terms of surveillance, in terms of laboratory. You can see the huge success in terms of laboratory. I think the continent is doing a great job, but we need to recognize we didn't have the system in place. This is why we can still see by building and sustaining a strong surveillance system, we'll continue to get more and more cases, but that one will control that because the system will be able to absorb these cases and to manage these cases. We are seeing also the decrease in terms of deaths. I think this is something critical. Yes, we are linking, if I have to move to the second question, we are linking what we are doing with Mpox to cholera, as we did with Marburg and Ebola when some countries were affected. I think you can see the trend as we presented, and I will maybe call my colleague from IMST maybe to provide more specificities to your question. Dr. Yap, if there is something you want to add more than what I presented.
Thank you, DJ. Maybe yes, thank you. Just to specify that for cholera, we really have the country that has been in the higher side, South Sudan, Angola, where we really see the decrease. And then DRC, it's also following the same trend. And as you mentioned, Congo and Chad, those are the countries that we are seeing it coming up. So what we can say now is we have this dual approach where we appreciate those who are going down, but we really want to control as soon as possible in those countries where we see the emergence. That's why also together at the IMST, we are finalizing the continental plan for cholera to ensure that we consider the two categories of country, those high-burden, the hotspot, but also those who anytime, because of their location, because of the exposure, can be having some case. Over to you, Margaret.
Thank you, Prof. Let's cross over to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor. Kemo, if you can hear us.
Hello there. Can you hear me? Yes, can you hear me?
We can hear you. Go ahead.
Okay, thank you. So I attempted to ask this question last week, but I couldn't articulate it well, and now I have it better in my head. I wanted explanation for the situation in Guinea. When it started, it had, according to reports, it had a very good, surveillance system in place, and they were responding very well. But last week, the reports didn't sound as, as good as that. I mean, given the situation, the worsening situation. I really wanted to know what has changed, and to get us to this point where we are, that the cases have increased as per last week's report.
Okay, Kemo, we can hardly hear you. I'll just read over your question. I can see it in the chat box as well. Thank you very much.
Okay. All right. Thank you.
So the question from Kemo is on the situation in Freetown, Sierra Leone. The question is, Guinea had strong active community surveillance at the beginning, and now the challenge cited for the country is the exact words of last week's report. Limited resources, weak surveillance systems, delayed case detection, and low community awareness affecting outbreak response. What has changed? So that's about the situation in Guinea. DG, back to you.
Yes, thank you so much. I know the question was about Sierra Leone and Guinea, and my colleague, Dr. Yap, was in Sierra Leone a few days ago to assess the situation there and also to support the country and celebrate also the success that they are making. Maybe I will let Dr. Yap to talk more about what is so in Sierra Leone, and that can be also linked to the situation in Guinea. Over to you, Dr. Yap.
Thank you. Thank you for the question, Kemo. Indeed, Sierra Leone is a country that we were quite worried at some point where we were seeing the curve quite high, but they really strengthened with the different visits of the IMST. They adjust their activities focusing on the community-based surveillance. So they had many activities, and they decided that for this month of August, the minister has decided to launch the 0 case by end of August, which really sent an army of community healthcare workers. And what they do in the field, which is quite impressive, is really the integrated response where you have the surveillance, but also as soon as there is one suspected case, because they have a high test positivity at some point, they will do the vaccination of the contact around. So the integration of those activities and the fact that the activity is really decentralized at the district level really make it successful, the finding of case in the community. However, this is one challenge that we've also highlighted, is the case fatality rate, because we realized that quite a number of their death was due to people who were having both HIV and Mpox. So they decided to put it as a clear priority for this month of August and ensure that the case management starts earlier, not at the later stage when nothing is no longer possible. This is what we can mention. And one critical point to come back to Guinea, and maybe Dr. Mori will add on that, is that they really strengthen the regional approach, where they want to share their experience between what they've been doing in Sierra Leone that can also be useful for Guinea. Maybe Dr. Mori.
Thank you very much, Prof. Yab. So I think for Guinea, maybe the situation, the AP situation is completely different from Sierra Leone. Of course, the number of cases is rising. There is no death. There is, I think they have what they used to call epidemic prone disease treatment centers, but maybe the hygiene conditions are not on top in this isolation units. So that's why I think they are struggling to get contact or no cases isolated in these centers. So this is one of the reasons why confirmed cases are moving from these centers and to go to home. But there are also, I think we have been providing them with some technical guidance and so on. So how to make sure that those people who can firstly improve the hygiene condition in these treatment centers, but also to reinforce the RCCE. And then I think in one of our meetings, we even called a Sierra Leone team to share their experiences, because in Sierra Leone, almost all the confirmed cases, maybe around 80% are isolated. You see, so I think they had some experience sharing between the two countries. Yes, so this is where we are in Guinea, but definitely the situation need to be improved in Guinea, because we are not yet, even at the continental level, we were trying to plan a country visit as we did it for Sierra Leone. Over.
Thank you very much. Let's cross over to the floor. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Thank you so much for this opportunity and thanks for the presentation. It was really helpful to see the change in the lab network and the vaccination approval rates and such. I wanted to ask several kind of outside Mpox researchers have expressed a lot of frustration over this past year and said that Mpox really isn't at a point where it's contained. And they've kind of said that kind of casts a question on how valuable this lever is of declaring a public health emergency when the globe hasn't maybe committed the resources and the political will to contain this. I wanted to see if you could respond to those kind of criticisms that enough hasn't been done to contain Mpox. Thank you very much.
Thank you, Gabriel. Back to you, DG.
Gabriel, this is so critical to discuss resources versus, declaration of a public health emergency of continental security. But let me tell you, yes, we didn't secure all resources we wanted. Yes, we still have major gap for the phase 2 of the response. But if we didn't declare Mpox as public health emergency of continental security, if we didn't put the IMST coming together with WHO, UNICEF, and all other partners, if we didn't budget the continental response plan, knowing where money must go, because mostly when countries are dealing with these kind of issues, on bilateral mode, it becomes a political issue. But by bringing that at continental level, we were allocating resources, vaccines to countries without this political burden that some countries are facing. As I'm saying, if we didn't declare that, surely we will not secure what we managed to secure to date. We had 13 countries, now we have 24 countries. We were talking about 599 million today. We need more, and this is why we are talking about the pledge of 1.1 billion. But out of 1.1 billion, we are tracking 977 million. I think we made progress. We cannot say, when people are making this comment, they have also to recognize the progress we made, and we are showing to you in all areas that we made progress. We will continue to advocate, we'll continue to talk to our partners, we'll continue also to talk to our member states. We are providing more and more funding to the system. I think we take it more positively, this declaration of public health emergency, to catalyze the effort to bring people together.
Thank you, DG. Let's cross over back to the floor. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much. The DG, I would like to ask the question, with this being the first declaration of such by the Africa CDC and looking at the mechanisms that were put in place in making such declarations, what do you think could be done differently or improved upon to make it more efficient to make a similar declaration for subsequent events? And I'm curious to know, with the cholera outbreak now being integrated into the IMST's workload, why hasn't cholera, with the spurge of outbreaks, qualified for similar declaration yet? And for the co-leads of the response, I'd like to know, going forward, what is now the next target for this Mpox outbreak response? Thank you very much.
Thank you, Paul. Back to you, DG.
Yes, Paul. Every day we are learning. Yes, we could do better, but we need also to say what we did was the right decision we made at that moment. I can quickly jump to cholera and to say, in 2023, 2024, we wanted to declare cholera public health emergency of continental security. For some reasons, including how Africa CDC was putting in place the group of experts, developing policies for the declaration of the public health emergency, we didn't manage to do that. But also we didn't manage to do that because we are not just declaring because we want to do that. We are declaring because we want to make sure that we mobilize all resources. With Mpox, we did it. Now, why we are not declaring cholera as public health emergency? Not today, we are not doing that because we are combining now Mpox and cholera response. We are not sure that if we declare cholera public health emergency for continental security, we can get more than what we are getting now. But what we are doing in Lusaka in a few weeks, President Ichelema, who is the AU champion for cholera, will launch the Continental Response Plan, the Continental Cholera Response Plan. It will be the 27th, I think, of August in Lusaka. That one will help us now with all activities that we are outlining in this response plan. We'll start to monitor the progress. As you know, cholera is mostly a multi-sectoral response. It's not just the health response. Health component is there, but we need other ministries to come on board to work together. That is requesting a kind of coordination mechanism, either at the head of state level or the prime minister's level. And you know, we are working on that, and we'll see the progress we'll make. I think in a few days, while we are making progress in Mpox, we are also making progress in cholera. We can now say what is the remaining component to make sure that Africa will be out of cholera in the next 5 years. I think this is what we are doing now. If after a few months, a few years, we don't make progress, we will not hesitate to declare cholera public health emergency of continental security and bring all resources together. But for now, we have this combined approach with Mpox.
Thank you, DG. Let's cross over back to the floor. We have Dorcas Wangira from the BBC. Dorcas, you have the floor.
All right, yeah, good evening. Sorry, my first question had been sent before the briefing, so maybe that's why. So I have two questions. One is, what is the situation update in Kenya? Because it wasn't in the slide today, but there is concern in the country over the growing number of cases, particularly even in the capital, Nairobi. And then my second question, also because there's the WHO official here, well, some quarters have been arguing that one of the reasons why WHO may not have declared Mpox over as a public health emergency of international concern is because CDC. So my question is, like, the DG mentioned that you probably may declare this over as a continental security health emergency in the continent. We will when it was declared over as a global health emergency, Africa was still dealing with Mpox. So what happens in the scenario that Africa CDC declares the emergency over at a continental level, and it's still a global health emergency at the WHO level?
So, Dorcas, could you repeat your second question? You were cutting off.
Did you hear all of it, or it was just the first part?
It's just the whole question. We had some bits of it.
Okay. So could you answer my first question as I try to just change my headphones? Must be the problem. On Kenya first, and then I'll repeat the second question kindly.
Sure. DG,
Yeah.
back to you.
Dorcas, you can write your second question, but I will maybe, if I understood well, you are asking what will be, what the situation if Africa CDC today decide to lift the status of public health emergency of Mpox in Africa while WHO maintains that at global level. If this is the question, just confirm, then I will respond to that. About Kenya, yeah, maybe I didn't present, but we have the situation, even we are comparing last week and this week. I think we saw a decrease in terms of confirmed cases from 33 last week to 25 this week. Yeah, a slight increase in terms of suspected cases, but what we see also 0 deaths in Kenya. And so far from the first day of declaration to date, we have 908 cases, suspected cases, 311 confirmed cases, and 6 deaths in Kenya. I think we know that mostly the outbreak in Kenya was driven by proximity with some countries, and it was mostly imported from other countries. But so far, I can say Kenya is improving. The testing rate is 100%. The testing coverage is 100%. You know, I'm mostly confident that the situation in Kenya will continue to improve, and Kenya will be controlling this outbreak very quickly. Then, just tell me if I had the right understanding of your question regarding.
Yes,
it was that if
yes,
Africa
yes.
CDC. Okay. Look, we are led by science, and at Africa CDC level, we have the group of African experts. We call that the ECG, the Emergency Consultative Group. And we have all of these experts coming together, analyzing data. These are the experts that advised the Director General to declare the public health emergency of container security. These are the experts who came twice to advise to continue with the status. If in a few weeks they come, they see the trend, they see all data coming from countries, they see the level of investment and effort, and they decide to advise the DG to lift the status, we'll do that because we are led by science. Most of our experts are also sitting with the IHR group in Geneva of WHO, advising the Director General of WHO to declare the public health emergency for international concern. If in Africa, we see that we are moving toward controlling the outbreak, and the response can become at routine level, and we decide to lift that. WHO, based on the trend from not only Africa, but all continents, they will also make a decision. If they think that there is still a major risk, and they see the transmission, and they see the number of countries being affected increasing, they can decide to maintain this status. It's not contradictory, but we can also have a case where WHO can declare that public emergency of international concern is lifted, while Africa CDC will continue to maintain, because in Africa we see that it's still a major public health issue. I think we are not led by politics, we are led by science, and we continue to be led by science for this declaration. I don't know if my colleague Dr. Mori and Yap, you want to add on Dorcas's question, while I will maybe request Margaret to give 30 more minutes to journalists, because I took 30 minutes to make a presentation for their questions. Over to you.
DG, I think you have said it very well. all these two committees are independent. So just to clarify this, they are independent, and they are chaired by experts across the world. And if they decide, as the DG has said, based on the epi situations, the different, because we used to do what we call risk assessment. So, and this risk assessment used to take into consideration a number of criteria. So they will be reviewing and everything's against these criteria. Based on this, if they said, okay, but because in the committee also, they have, it's a group. So if they decide, they have a consensus and they decided to lift it, of course, the fake or the fakes will be lifted. But it's up to, they only have the responsibility to propose. They only have the responsibility to propose. The DG Kaseya, for example, can accept or not accept what has been proposed by the committee, as well as for the DG Tedros. So this is what I just wanted to add.
Yes, and maybe to mention that the lift of the facts, it doesn't mean that the response has ended. That's why in the plan, this part is really the integration and the legacy. So once we move toward the end, we will equip. We believe that the country has been equipped. We have a couple of National Public Health Institute and agency. Through this Mpox, they've really built themselves. I'm talking about DRC, Sierra Leone, and others. This was the first time for some of them to respond to such outbreaks. So now that we are more confident, and they are more confident in their ability, it will be easier in a way to integrate the response within the national health system.
Maybe in addition to what Prof. Yapar just said, before maybe a lifting, I think they used to make recommendation. So the recommendation will follow, okay, we will be lifting the fake or the fakes, but we are recommending, countries to implement this to sustain, the gain or to foster, the response. Yeah.
Over to you, DG.
Thank you. Let's cross back to the floor. We have Kerry Cullinan from Health Policy Watch. Kerry, you have the floor.
Thank you, Margaret. My question is on health financing. Last week in Ghana, there was an African health sovereignty summit, which once again raised the possibility of an airline tax. This has been spoken about for several years. So I just wondered whether there has been any progress on this and whether there is some organizational group that's driving this. And also, I wanted to know whether there has been any further contact between the US government and the AU or the Africa CDC on health financing, given that they have withdrawn such a massive amount of funding so rapidly this year. Thank you.
Thank you, Kerry. Back to you, DG.
Yeah, thank you, Kerry. We want to repeat and to say it loudly that Africa didn't wait for EDCAT to start with the innovative health financing model for the continent. In September, I met President Kagame. He wrote to all African head of state in October, and let me remind you that October was before the election in the US, before the election in Canada, before the election in Germany and other countries. Then, our leaders, they met. We met in February, and we produced what we call some of them are calling that the Green Book, the Rethinking Africa Health Financing in a New Era. All strategies are there. More domestic resources, more innovative resources, including airline tax, including what DRC is doing now to tax imported goods, 2% for health, including tax tobacco, sugar, and everything. Countries, they have a number of areas for their action. We are also talking about blended finance, how to bring more funding for investment. And we are talking also how to build strong governance mechanisms. The meeting in Ghana, it's a good meeting. It's just a continuity of what is already done. because there is nothing new that will come there if it was not discussed in AU. And I have also to say that we have a champion. Our champion for health financing is President Kagame. And in Africa, we like to respect that. And for the next steps, if there is a leader who must talk about health financing and bring other leaders together, is President Kagame. I think we are all in agreement for that, while we are also respecting initiatives that can come from any other African country to see how we can make progress. Especially with the US, you know, we still have what I call positive dialogue with the US government. And one of the outcomes of this dialogue is for PEPFAR, we manage it, you know, we cannot say it's just Africa CDC. So many people, they came. But I have to say what Africa CDC did. Myself, I flew to the US 5 times. I met congressmen, senators, and representatives. I met White House people, State Department, and all other agencies. You know, we are all combining effort. Now, we secured some funding under PEPFAR. We are still talking to them. As I said, for the peace deal, we managed to put a strong component of public health for investment that can be guaranteed by DFC. You know, we have a number of areas of engagement with the US. We will continue, and we hope that that will become a positive, we can get a positive outcome from this engagement. Over to you, Margaret.
Let's take the next question. We have Kumba from Gambia News Daily. Kumba, you have the floor.
Good afternoon from the Gambia, and thank you for giving me the opportunity. Actually, I have 4 to 5 questions, if the time permits me. I was unable to be part of the last meeting last week, so I was able to ask these questions. So going to my questions, first, I would like to ask, you know, given the ongoing Mpox outbreaks and the limited vaccine supply across Africa, what concrete step is Africa CDC taking to ensure equitable vaccine access for smaller countries like the Gambia, and how can we integrate these vaccines into our national preparedness plans? The other question is about malaria. We are in the rainy season. In the drive to have malaria eliminated, I would like to ask Africa CDC, how can Africa CDC strengthen Gambia's malaria elimination efforts through cross-border collaboration, new vector control tools, obviously, and the data-driven decision-making processes? And also, I would like to ask about the climate change issue and the health risk. How can Africa CDC support Gambia in building climate resilient health systems, including vector control strategies to address shifting disease patterns caused by environmental change? The other question also is the laboratory enhancement in the Gambia. Of recent, Gambia has built 2 bigger laboratories in the country to advance laboratory activities and coverage. I would like to ask, what resources and training can Africa CDC provide to enhance the Gambia laboratory capacity, especially for genomic sequencing to detect and trace emerging infectious diseases faster? Thank you for giving me the opportunity.
Thank you. Back to you, DG. There's loaded questions there.
Yeah, a lot of questions, but we have many colleagues. I think Dr. Yenu and the team for lab, they will respond. I know that we have also colleagues who will respond on the climate change, because we are working to support country build climate resilient system. On malaria, I know also my colleagues working with primary healthcare division are there. They will also provide response. But I wanted just to make a general comment to say, Kumba, in Africa CDC, we don't have big country, small country. We have all 55 countries. In AU, we are talking about 55 countries are at the same level for us. If there is an outbreak, we will make sure that all countries have access to all medical countermeasures. It means vaccine, medicines, diagnostics, and everything. Have access to capacity building, and this is also what WHO is doing. I think we have country offices in all countries. There is no country without WHO country office. And I think today, if we assess the situation in Gambia and we believe that Gambia must receive vaccine, we'll do what we did for Sierra Leone, what we did for Burundi and other countries. Gambia will get the vaccine they need to respond to outbreaks, even Mpox or other outbreaks. But let me call my colleagues who are specialists in all other areas, maybe to respond quickly. I don't know, let us start with malaria. I don't know, colleagues from Palm Healthcare, if they are there. Okay, Dr. Yap, maybe you can respond to that while we look for colleagues for lab to come up.
Yes, actually, there was a question on vaccination that we have our pillar lead, Dr. Charles, who would like to bring some more addition. Charles.
Thank you. Thank you so much. Thank you so much, Prof. Yap, and thank you, DG. So just to quickly respond to the question on vaccines. Yes, currently we have some, quite some number of vaccine doses on the continent. However, this has not discouraged in any way, like the DG did mention, us reaching out to countries to try to get what the demand picture looks like. So currently we're engaging with countries and we, at this level, we have what we have termed the access and allocation mechanism that ensures equitable distribution and allocation of vaccines to countries. So we are currently having some countries in the pipeline, all active countries with active cases. What we are currently doing is to reach out to these countries to try to get a sense of what the demand looks like. So this would help us to forecast for what the need would be, and also as we mobilize for more vaccines to support these countries, where the IMST has continued to, provide that guidance and that willingness to support countries, not minding what the situation is in the country. Our target is to ensure that all countries have equitable access to these vaccines, like the DG rightly mentioned. So currently we are keeping track of this. We also have other countries apart from Guinea, apart from Gambia. We have South Sudan in the pipeline, Tanzania in the pipeline. We have Mozambique in the pipeline. So all of this, we are collecting this data, which will help us shape the demand picture going forward. Thank you, and back to you, Prof.
Yes, so maybe we can let Dr. Yenyu for the lab question, if he's connected.
I don't think he's connected. He's not connected.
Okay, if it's not connected, then I can take it. The way we work, as the DJ mentioned, there is no small or big country. So since Gambia has actually reported case, the first thing we do is to engage with the country to really assess the situation. Gambia is a country that has the MRC capacity. They have some good capacity, but as the IMST, Africa CDC, and WHO, we reinforce also the national system. So we did an assessment, and Gambia has already received some reagent to ensure that they implement not only the detection, but also the genomics. And there is a continuous support, because beyond the reagent, you have the training on bioinformatics and so on. So all those are in plan to ensure that Gambia become autonomous, as most of the other countries, in the capacity for them to do the testing, but also the sequencing, because we have that target of 8%. Each country should be able to do the sequencing so that we have a proper monitoring and the evolution of the different clades. Over to you.
Thank you. We have now taken the last question. We have Agnes from News Vision in Uganda. Agnes, you have the floor. Agnes, if you can hear us.
Yes, I can hear you loud and clear. Thank you so much. Thank you for the good presentation, DG, and bringing us to speed in regard to the outbreaks. Yes, my first question, I had typed in the chat, my first question is about the 12 months of the Mpox fight. It's 12 months since it was declared a public health concern. So now we continue to see countries come on board. We continue to see that there are new cases, confirmed cases, and even death. So what is your call to action? The good thing, I can also see WHO represented here. So what is the call to action? And are there timelines for the countries to see that we eradicate Mpox? Then the second question is about the vaccines. You said we are celebrating the vaccination success, but you said the only limitation is lack of vaccines. So what is Africa CDC doing to ensure that affected countries are able to access vaccines for their population? Over to you.
Back to you, DG. Thank you, Agnes.
Thank you, Agnes, because you wanted WHO and Africa to speak. We are represented in IMST. You see, these two gentlemen who are there. Then I will give them the floor. They will respond to the two questions, then I will conclude. Over to you, colleagues.
Okay, I will start with the question on the vaccine. So currently talking about Uganda, Uganda currently has around 97,000 doses of vaccine that are in country. They've planned the next round of vaccination that will happen in the next 10 days, if I'm correct. But this is a country that have managed not only to absorb, but really to use very efficiently the dose that has been made available. Now, to move forward, both WHO, Africa CDC, we are moving toward what we call the fractionate dose, where you can use one dose of vaccine that can actually vaccinate 5 people. And Uganda is one of the countries that is going to lead that first pilot because it has not been happening in the country. This is one way of responding to the low number of those that we currently have. The second one is to continue the mobilization. As DJ showed in one of the first slides, the pledge last year were 20,000 doses only. And now we've managed to reach 3 million. So now we need 3.4 million to actually contain the outbreak, but we should think beyond that. As we are transitioning to integrating the Mpox response in the national system, we are also thinking of those endemic countries. What will be the demand? How will we ensure that they have adequate vaccine? So that is a conversation that we currently have with our partners, but also pushing the agenda of local manufacturing. Because the local manufacturer also rely on the demand. If we have enough demand, then we'll be able to have the confidence to be able to transfer the vaccine production to local, as was asked in the beginning. So maybe the Dr. Moi will answer the question on after 12 months, what are the plans in terms of transition and what is the call for action to the country who are seeing some new cases?
Yeah, thank you. Thank you very much. So for this question, maybe the first question you have just answered, I just want to maybe supplement one element. So, vaccine is crucial and important, but not the only countermeasures. So we are also encouraging countries to make sure that the other countermeasures are implemented, properly, because the experience from Burundi, for example, is a good example from Burundi. So I just want to emphasize on this before. So for the plan, now after 1 year, we all know that, the fakes, we were just discussing about the fakes and the fake. These are two, like, I will call them like fatal weapon for us, for Africa CDC and for WHO. So we used to use this when, you know, the situation is like a critical. And when the situation like seems to be under control, we all need to, you know, lift, because we have to make good use of this, you know, like fakes and fake. Otherwise, it's gonna be like people will continue saying, so maybe fake is not something very important or like crucial for global health. You see, so that's why we are now trying to make sure that it's well used in the condition where the situation is showing that it's critical. So after 1 year, of course, we are now, I think Prof. Yapa said, we have starting developing a transition plan. Our idea is how to make sure that, you know, Mpox detections, isolation, everything is like included in the routine systems, but with a technical guidance, because we know that there are some risks, there are, you know, some aspects that need to be taken into consideration while implementing, even like home-based care and so on. So all these things have to be put together to have a clear and evidence-based. We don't want to create like a situation in which we will be coming back, you know, to the situation where we were like dealing with a high burden in the different countries. This plan will be like our way forward. You know, maybe the IMST will continue staying in place, but the plan will change, because this transition, we wanted the country to own it, to also implement it as quick as possible, so that we are confident that, but now in terms of capacity, I think we are confident that most of the country have now the capacity strengthened. Maybe they just need to be guided now how to make sure that, you know, this new plan is implemented. So this is what I can say. So the vaccine will be there. Maybe we will continue, but honestly speaking, my personal point of view, of course, we are seeing a significant decrease in the different countries, in the high burden countries, but nobody can guarantee you, nobody can tell you today that in 1 week or in 2 weeks or maybe in 1 month, we will be ending with the outbreaks. Nobody can give that. But we are working, you know, as IMST to give the tools to the country to deal with the with Mpox as like endemic in some countries, or as you know, like a disease like others. I'll stop there.
Oh, over to you, DG.
You said everything. I think Margaret will want me now to conclude.
Yes, with that, we have come to the end of the briefing this week. Back to you, DG, for your closing remarks.
Thank you. Thank you so much, colleagues. We rely on our colleagues, journalists, to help our communities to be well informed. Africa CDC decided to maintain this weekly press conference to give you an update on all outbreaks and to have opportunity to exchange. Myself, I will continue to attend, but if I'm not there, as you saw, I have strong colleagues, Dr. Mori from WHO, Dr. Yap, and Dr. Ngashi. At least you must make sure that every week you have the press conference, and I will make sure to attend regularly. We are led by science. We know all challenges we are facing in terms of availability of vaccine. This is why we have a number of studies for fraction doses that are ongoing, but we are also pushing the agenda of local manufacturing. We can just do our best, and I think we'll update you on progress we are making, because you saw now Africa is manufacturing our own diagnostics for Mpox. We are manufacturing a number of other medical countermeasures. In the next few weeks, we'll call for a meeting of ECG to advise us if we need to continue the public health emergency status, how we need to lift that. And also in a few days, we'll have this meeting in Lusaka to launch the Continental Response Plan. It's also an opportunity for us in Lusaka to call for all partners to really implement the Lusaka agenda in terms of alignment. We want to see more funding coming from member states and more alignment of our partners. And with that, I really thank you so much, and I hope to see you very soon for another press conference. Thank you so much.